So the title of our next discussion and presentation is Health-Trust-Brotherhood with Professor Glassberg. He's a board-certified general surgeon and holds an appointment as a professor of surgery at the Elon University in Israel and as associate professor of surgery at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. Be speaking for the next 12 to 15 minutes. And again, we'll have a short question and answer session after. So I encourage everybody to check out that chat bubble. Professor Glassberg.
Good evening or good morning, depends on which side of the globe you are. Thank you for the opportunity. It's a true honor. What I wanted to share with you is actually not a medical story. It's a story about mankind and about trust and about brotherhood, which the title says. I'm the new Surgeon General of the IDF Medical Corps. I'll say a word about it in a few minutes. I actually stepped into office, and a week and a half later, 2 weeks later, we started this collaboration with Elon. And I'm here thanks to them. So thank you, Dr. Halbertal, and all the team. I will minimize myself so you can see the slides. Medical Corps, actually we have two assignments. The first responsibility that we have is, of course, to maintain the health of our force, of our troops, and in plain words, help the military win wars. But in between, we provide care to the IDF personnel, and which is unique, we have a hat. I wear another hat, which is a national hat, and we help in the preparation of the national system, to the readiness to anything from the national disasters, earthquakes, fires, whatever you can imagine, which actually, under wearing that hat, I do not answer to my commander. It's a national role that has nothing to do with my military job. I actually do both. And I heard before that you have a California hospital committee. We have sort of such a thing, a national community, and I'm a member of that. I just mentioned that this is different from what we use the same term, but it has a different meaning. We use Surgeon General not to speak about my good friend Admiral Adams, who in American, Surgeon General is more of the public health position, and with us, it's a commander of the medical corps. So we have one medical corps, which is again different than the United States. You have an Army, Air Force, Navy, National Guard, and medical corps. We have a single corps, one SG, and we focus on, of course, on combat casualty care. That's what we do. I'm a surgeon. I'm a trauma surgeon. I don't believe in cytokines. I've never seen a virus. All the jokes are about me. We focus on pre-hospital care. We do not have military hospitals in Israel. We gave it all up in the 1950s. And I'll go back to it in a minute because I'm laying the floor here or laying the bed, here to talk about the challenges we had. We only care about active duty personnel, which means my providers do not take care of children, do not take care of elderly, and no, we don't take care of beneficiaries. This is us. I'm a flight surgeon and a member of the Airborne Search and Rescue Unit, as well as Dr. Halbertal. We both have been in that unit for many years. He's a reservist. I'm still active duty, but we do the same. And we rely on junior providers. Our physicians, our nurses are young. You can see the pictures speak for itself. They're straight out of medical school, general practitioners. Our nurses and our paramedics and our medics, the paramedics and medics are 18, 19 years old. Our nurses are 23 years old, and our physicians are 25 to 30 years old. Because they're focused on pre-hospital care and trauma care. And for you to be able to chase the guys wearing greens and running around in the bush, you have to be young as them or as close as possible. We are built, I'll waste one more minute of your time just to explain where we're coming from. We're divided into regional commands in Army, Navy, and Air Force, and we have a Surgeon General for each of them, but they all answer to one Surgeon General. We have something called the Home Front Command, which is the command that's in charge of preparing the national system for disasters, as I mentioned before, focused on war, but it also does other things. We think a lot of R&D, and like you can imagine, the military, bright young people with all their ideas, and we have true hardcore medical research. We have our own military medical academy, or medical, including a med school. And we've also been involved in disaster response and humanitarian aid, and these are just a few of the examples that we went through over the last few decades. You've probably heard about Haiti, but we've since been to the Philippines and twice in Nepal and in Japan and around the world. So we have some humanitarian experience, but we've never, and I'm sorry, I led the operation with helping the Syrian refugees for the last few years. But we've never taken care of our own citizens. The IDF actually, since our establishment, this country has never deployed our military to take care of our own people. And COVID came and changed it. What were we doing when this hit? So we, of course, dictate our own policy. We have a public health branch, and we within 5 days transferred our DNA laboratories to become an RNA PCR laboratory. We have our DNA laboratory for the identification of remains. It's a forensic laboratory. We switched, and within 5 days, these are things you can only do in the military. You give an order and they go work. So we had our own, we actually had the entire food chain, anything from who gets to be sampled through sampling and teams to go to the homes or the units and back to laboratory, and we built the IT around it. So we held the entire chain. At the beginning, we were the only ones. I mean, the national system was a little bit slower, but of course, the scale is a lot bigger. This, by the way, allowed us to have more rapid, I would use the word insights or learning, because when you have the entire chain, you can go back and see, well, who turns up positive, and go back to the system, similar symptoms, and learn from that. But then, as I said, in September, I stepped into office, and we, Dr. Harbital and myself, under the auspices of the National Ministry of Health, decided we were going to take a new path of collaboration. The idea was actually there since April or May. Dr. Harbital can correct me, but it was not. It had come to a point of actually deploying this capability. I personally thought that it's time for us to join the national system and do our share, and that's how we ended up in the underground hospital in Rambam. Just for you to understand how big of a leap that is this is how we provide care on on regular basis. We provide first aid for wounded, or what we call role 1, care for trauma patients, or sometimes role 2, and we do the ambulatory care and primary care and public, occupational health and the general practitioners and the family practitioners and all that. We also have outpatient care. We have specialists, but we do not have hospitals. We send our soldiers or servicemen or women to the hospitals. During this crisis, for the first time ever, under Operation Brotherhood, we call it, we actually switched. We came up with a new model, which is not only we send our people to the civilian hospital, but civilians come to us. For the first time ever, we had military-run departments, which is, as I said, a huge challenge. Remember who we are. Remember how young we are. Remember our dreams are not customs with all the challenges that are involved. I was trying to come up with comparison for you, so I looked at Stanford Children's, and it's sort of like they're going to tell you, well, you guys you're going to go and pack your bags. You have 72 hours, and you're going to stop providing care in Afghanistan, combat casualty care. It's sort of like the opposite. So it's a huge shift. It's not to be taken for granted. And then we end up in the underground hospital, and Dr. Harbital has already shown you. We came with our, as the military tends, you come with your own IT, your own logistics. So we came a little bit overpowered and deliberately, and assisted Rambam. And I'll give you a few examples about what we mean with standards. But we brought our staff and joined Rambam in this struggle. I think the biggest contribution lies beyond the number of beds we added. It's not a technical thing, and I'll go back to it in a few minutes when I conclude. But I truly believe that the huge the biggest success we had is about the collaboration we formed. We did that within 10 days. The government decided on Thursday. We had Friday and Saturday when we gave our providers a heads up and told them, each one of you say goodbye to your unit. Sunday morning, we work on Sunday. Sunday morning, they showed up in Rambam, and they took us 7 days for them to start running their own departments. We brought, as you can see, nurses, physicians, operational officers, physiotherapists, pharmacists. We pulled them out of their units. Regimentals, doctors. We brought the SEAL doctor, the Delta doctor, the Green Berets doctor, Air Force, Navy, Army, all of them. Not all our providers, but from every unit. We pulled the people, even from the Homefront Command. Although the Homefront Command is busy assisting the national system, we still pulled a few just for them to be part of this. These are our numbers. We came about 100 people. You can see we brought 15 senior physicians. We do have senior physicians with us. They tend to be our commanders, like the higher end level. We pulled all our internalists and pediatricians and family practitioners, all the senior ones. We brought them. We brought, as you can see, 48 general practitioners and nurses, and you have the breakout in front of you. And then they changed clothes and they sit down with people from Rambam, and they start learning. And these are bright young people. Their learning curve is very, very steep. I especially enjoyed looking at the faces of the guides, of the senior physicians and senior nurses from Rambam. You get the guys on Monday morning, they do the first training. They all came out with their, I don't know if it's the right English term, but falling faces, like pretty concerned. And within a few hours, these guys became a team and started working together. I think what brought us together and made this a success is the fact that we shared we have shared values. We're all part of the national health system. We all care for the patients first, and we came fully prepared for the mission. We took individuals and made them into teams. The Rambam assisted us with a training center, and I know Gila's going to talk about it. Built teams very, very rapidly, and I said it took 2 days for them to get acquainted with the IT system, protocols, all that. 2 days of training, and then 3 days of working in the wards, and then they became a team, and then they started running on their own. We insisted on maintaining the routine of a department. We have morning rounds and morning meetings and how do you call it, when transfer between shifts, and learning and journal clubs and all that. And these are, as I said, these are challenging providers. They come up with the latest article, and they will always, we encourage them to challenge us because although we're in the military, we still think there's value in that. And so it was a constant learning and improving. This is a physiotherapist taking care of vulnerable patients. At the beginning, we did not think about bringing physiotherapists, but we went there, saw this Rambam standards, and we decided we're going to meet the standards and even go beyond the standards. I really think that was something we insisted on. For example, we decided we're going to have more cameras. You probably did the same thing. You put cameras to watch the patients. So Rambam had a standard of an HD camera per 4 patients, and I insisted on a camera per patient because our providers are more junior, and I wanted our team to be able to sit back and observe and assist from afar. In a few days, we learned that was an overshoot, but we brought more nurses and more physicians per patient just because we wanted to make up for the fact that we're more junior. One last story is this is a patient who actually what we provided was end-of-life care. He's 92 years old, numerous background diseases, mentally already deteriorated when he came in, and he was actually dying. This is something that in the picture you have a physician, a nurse, and a medic, an 18-and-a-half-year-old girl. You can't tell it's a girl, but it's a girl, the lady in the center. And they're not accustomed to that. We don't have end-of-life care in the idea. If we don't provide that, we take care of 18 to 21 years old. or maybe sometimes older, ancient elephants like me, but in general, young and healthy people who sometimes get wounded and get injured. And what she did, the medic, and we were especially concerned about how their mental status, how will they handle that? And they surprised us. This patient was dying, and all she did was stand next to him and hold his hand because the family can't be with him because he's all alone in the world. And I see that not only as something that I mean, we had a few cases like that, and this is something we're very proud of. And I actually think that they have exceeded our expectations from them. One last thing I want to mention is I think the fundamental factor that surrounds this, we call it operation because we're in the military, but is trust. In this picture, you have Dr. Albertal on the right, and you have the commander of the operation, Dr. Kopp. He's a Northern Command surgeon and every day on an unregular basis, but then we pulled him out to command this mission. We have a nurse, our military nurse, with her back to us. We have Dr. Gila Himes, who's the chief nurse for Rambam, and you have this general who's the number 2 general, the number 2 in the IDF. And I use this picture to talk about trust because I think there's a lot of trust. And Dr. Habatal had to really trust us to allow us to come and assist in his hospital. And for us, I think the highest level of trust is for someone to trust me with their loved ones. And these could have been my parents or my brother or my sister. And for us to be able to do that takes trust on both sides. So we trusted Rambam to guide us, and they trusted us to stand up to their standards. And I think that this is something that if I can pinpoint what we gained here is we show the system that if you bring 2 different systems, we came from a different planet almost. And there were lots of people were very worried, both in the Ministry of Health, even us we were worried. But they trusted us, and I really think there's something that we gained out of this. This is the military. We have to hold an after-action report. We've actually done that last week. We think the mission was a success. We took care of dozens of patients, and the professional supervision we got, including from Rambam and the Minister of Health, says we did a good job. We were able to build individuals into a team, and we offered them not only group development, but also personal development. That was a very, very powerful experience for our team. We had an impact on the national resilience because people were, at the time we stepped in, the country was looking at, people were talking about, this is going to be Italy. And they took us off the shelf and brought us to assist the national system, and I think it helped. And looking forward, now we have a new national resource, which is combining 2 systems that never worked before and then augmenting the national system capability. This is the last picture I want to show, and I think it speaks to itself. We have gained as a nation 120 young, brilliant individuals who are our next generation's leadership, and they know how to talk to each other. They'll learn new languages. The nurse who's never served in the military work with a physician from the special forces, and our medic who is in the military work with a physician who is Muslim. So we have something new here, which is a hybrid, which is, I personally truly believe, is greater than the sum of its parts. 6 take-home messages. I think if you combine trust, flexibility, and professionalism, any model ceases to be unique, and you can rapidly build new capabilities, and especially look at the next generation and show them that together there's nothing we cannot do. Thank you very much.
Thank you, Professor Glassberg. So one of the first questions we have is how much of the strategy that you discussed was using what you've done before with prior disaster events or prior training versus creating in completely new ideas, new processes, building from the ground up, essentially?
It was actually building it from scratch because we have a field hospital. Because as I've shown, we've been around the world. But our field hospital, our disaster capabilities, our war capabilities are all based on reservists. We will pull Dr. Bahus. Well, technically not Dr. Bahus, but maybe we will pull out Mickey if we ever have to go to Haiti again. At times when it's a national system under stress, you cannot pull out all your experts from the hospitals. I actually didn't pull. I have 300 physicians embedded in civilian hospitals as we speak, because we don't have military hospitals. You do your residency in a civilian hospital. I didn't even pull those out. We did this entirely on our regular, active duty, very junior staff, in order for us not to weaken the national system on one end and augment on the other one. So that's why we could have not learned from things we've done before. It was a little bit complex, but I think you got the point.
Just a little bit. So I know working in emergency medicine and with our trauma colleagues like you, that so much of what we do comes from the combat care world and transitions over to civilian care. But you also mentioned that prior to this, not really having to think about cytokines and the detailed epidemiology, the granular microbiology. So we've all sort of experienced a paradigm shift with this pandemic. But you also said that some of the things you did were so extraordinary, it could only be done with military support and with the system in place. But do you think that you can identify some of the, whether it's flexible thinking or just other strategies that you employed that we could transition over to the civilian world? Because again, we're so dependent on our military experiences for our learning.
To be honest, I think this is one of the lessons that we've not learned yet. I mean, and we did not articulate it. When I will ask you to give me a year and call me back for the next year's session, and hopefully the COVID will be done by then, but we can still learn. It won't take me a year, but I'm not ready to answer, not because I don't have an answer, but because I worry this answer is mine, Elon's. And I really believe that we have to go back to our people and learn from them. What I meant was when I mentioned the strength of the military is the fact that when we come in, we bring the military logistics. You need a new, you want a new ER, so we built 5 new huge tents within 24 hours. You need IT people to combine 2 systems. So we bring some guys from the intelligence, and they will stay up all night and do that. So I meant things like that. I really think that it was mentioned before, command and control is a big thing here, but Dr. Harbital and also already brought in the military way of thinking into that. I truly believe that our contribution here was not being military per se, but it was being young, very, very enthusiastic providers who ask questions and accept nothing as they don't accept anything as a fact. So I think it's a good thing. Other than that, I promise I'll do my homework and I'll write back.
Well, we can look forward to maybe the information coming out of next year's collaboration. Now, you mentioned again just that young learner, and I know that we talk about a lot of the differences between some of our younger learners and our more experienced learners. Were there any points that were difficult for people? I know we could spend probably hours dissecting the challenges that we had with messaging and getting everybody on board with science. Were there any points that were difficult for people, or as a whole? You talked about, again, having to make that major transition from normal combat casualty care. Was it a PPE issue? Was it just kind of understanding how this virus works compared to what we're so used to combating? Were there any areas of friction or resistance encountered?
Well, people will actually, and we're still involved in Rama, right? But people are actually truly excited. I mean, they were truly excited. We had an issue with people showing up to shifts that they were not scheduled for. I mean, more people want to contribute than we actually had room for. I will mention that there was a difference between the way the way the different occupations reacted. For the physician, it was very easy. They sort of landed on their feet within 48 hours or 72 hours. They were running around the world. It was nurses had it was the biggest leap for them because our nurses are technically they're nurses. They're out of nursing school, but they have almost zero experience. What they do in the military base is give flu shots or measure blood pressure or do the routine medical care. And here they have to take care of a ventilated patient or, do the 24-hour care and deal with medications they've never heard of before. So for me, I read the article and I ask the pharmacist and I do what they tell me to do. For the nurses, it was a bigger leap, but it took them, I think within the second week, they were running on their own. We still insist till now that we stopped at the beginning, we had combined teams. We had a senior physician from Rambam rounding with us. That went away within a few days. We still have senior nurses from Rambam rounding with us because that's still a challenge. So there's different populations, but in general, these were all people trying to do their best. We didn't have any cases of people holding back.